This lesson is going to feel like a hodgepodge because it is. We cover other ortho stuff elsewhere, fractures in trauma, common injuries in common injuries. This is sort of the stuff that's left over that is both pediatrics and orthopedic related. And because of that, I'm not going to do one summative review at the end. I'm actually going to pause and review each section. More than usual is going to be focused on test prep. The things in this lesson naturally fall into being tested against one another. And so each section is going to be a question you're likely to see either on your pediatric shelf, your surgery shelf, or licensing exam. We're going to start off with the first of our subjects, the pathologic pediatric hip. And this is the game you're going to play. You're going to be asked to identify the disease state. And then just on licensing exams, you can generally get the answer by knowing the patient's age. But there's going to be some sort of patient demographic and age that the condition presents. You're going to have to know what diagnostic step to get in order to evaluate it and how to treat it. And you'll notice that our patient DXTX follow-up sort of gets turned on its side as we build the table. The first diagnosis is developmental dysplasia of the hip. This is going to be a diagnosis you make in the newborn nursery. The patient is going to be less than 3 months old, and they present with a physical exam a clunky hip. Not a clicky hip, but a clunky hip. This is a problem of the acetabulum. The head of the femur is against the acetabulum, but the acetabulum is not deep enough. Thus, when you do the Barlow or Ortolani maneuvers, whichever which way, abduction, adduction, what you're trying to do is dislocate or relocate the femur. And when you do that, and bone comes on bone again, you feel a clunk with your hands. If you feel a clunky hip, it's likely developmental dysplasia of the hip. The diagnosis is actually a clinical one, although an ultrasound may be used after 4 weeks. The problem is that the acetabulum knows to grow deeper and around the head of the femur because the head of the femur is present and the muscles and ligaments are holding the two together. If the head of the femur doesn't contact the acetabulum, it won't grow. And so all that's needed really is a harness to keep the head of the femur where it belongs. And because the head of the femur is up against the acetabulum, acetabular growth fixes the problem. The next diagnosis you're going to see everywhere else is Perth's disease, or Legg-Calvé-Perth's disease, which is an eponym that's not helpful. Instead, you should learn it as idiopathic avascular necrosis. It is not known why it happens, but it does. Most importantly, this is not the product of a growth spurt. And so you're going to see this in single-digit aged kids. 6 years old, and being idiopathic, it also helps as a memory cue to remind us that this is going to be insidious. Like avascular necrosis in an adult, it is painless. Slow onset doesn't hurt, but the head of the femur is undergoing avascular necrosis, which means that the child will not be able to bear weight. But because it is chronic, you're going to see this as an anthologic gait. What that means is one hip joint is unstable. The child knows, can't put weight on that. I'm going to try to walk anyway. So it will favor the good side, lingering on that side with that side's foot down, and very quickly getting off the bad leg. As soon as contact is made, there's an opportunity to switch back over to the good leg. That's what an anthologic gait looks like. The diagnosis is made with an X-ray. The best test is technically an MRI, but it is rarely needed. The head of the femur is supposed to be rounded, a spherical shape. Avascular necrosis, it does not look spherical. It's smaller, shorter, and floppier than the unaffected side. And sort of like developmental dysplasia, if you just let the kid grow, the body will reabsorb the necrosis and reform the femoral head. The hip is a weight-bearing joint, and so constantly walking on it causes trauma, preventing it from healing. And so if there were 16, you'd give them crutches. But being 6, you have to find some way, and you don't have to know the details, of removing the weight from the joint. And allowing normal femur growth will fix the problem. The third on this table is SCFE, and I call it SCFE because its actual name doesn't make any sense. A slipped capital femoral epiphysis. The epiphysis of the femur that is towards the caput proximal appears slipped on X-ray. Rounded spherical femoral head, the epiphysis normal. Femoral neck. In slipped capital femoral epiphysis, on X-ray it looks like the epiphysis is out of alignment. In X-rays, the epiphysis is ossified, so is radio-opaque. Femoral neck, radio-opaque. The physis, the growth plate, isn't. There's not nothing between them. They're just not visible on X-ray. So when it's slipped, it means that there's damage to something, that it's not of ossified bone. I want you to think of this like a miniature fracture in a miniature person. You'll see why. SCFE occurs during the growth spurt. Adolescence, 13 years. It is acute, it is painful, and will show the inability to bear weight. As the long bones grow longer, the muscles need to accommodate. The hip is a weight-bearing joint, and so if there's going to be damage to the hip joint, it'll be muscles pulling and lots of weight. So this happens most often in the unathletic, non-active, overweight children during their growth spurt. When you see adolescents, acute, painful, unable to bear weight, X-rays are not enough. You need to know to get the frog leg version. This exposes both of the acetabulum and the femoral heads. The femoral heads will be nicely seated in the acetabulum, but the rest of the femur will be out of alignment. And so it looks like the epiphysis has slipped, but really it's that there is a disconnect between ossified centers. That means the chondrocytes that are still present have been injured. And just like an intertrochanteric fracture that requires plates and screws to reconnect the trochanters to the femoral head through the femoral neck, SCFE requires surgery, pinning. And just as an intracapsular femoral neck fracture has risk for avascular necrosis of the femoral head, So too is SCFE, a risk factor for osteonecrosis, aka avascular necrosis of the femoral head. Now, you can notice the 3 months, 6 years, 13 years. You'd be able to do this strictly by age alone had it not for the last two. Septic arthritis is an infection of a joint. It can happen in any age, and it is acute, painful. And if it's of the hip, there will be the inability to bear weight. Only a septic arthritis is a septic arthritis. It doesn't really matter if it's in a kid or an adult. It's sepsis. So there's going to be a fever, leukocytosis, and elevated inflammatory markers, ESR, CRP. A red, hot, tender, swollen joint needs a tap. An arthrocentesis will show more than 50,000 white blood cells and enable a culture. And for this discussion, I don't want to get into the details about organisms and antibiotics. It requires antibiotics and drainage. And you may get into organisms a little bit, but if you see Neisseria gonorrhea, that may be an indication of sexual activity or sexual abuse, depending on the age. And then the last one is there for licensing exams. Transient means it will go away on its own. Tenosynovitis, swelling of the joint. This also occurs at any age. It will be an acute, painful joint. If it's of the hip, there'll be the inability to bear weight. Only there won't be signs of massive inflammation, and there will be a history of a recent viral illness. The reason why this is on this list is because the diagnosis is made clinically, no need to do an arthrocentesis. The treatment is NSAIDs and a little bit of time, and there's no reason to do antibiotics or drainage. And this will resolve spontaneously. Think of this like bacterial reactive arthritis. So you can see that none of these are like each other, but it makes for a nice table, and there are 5 of them, which makes for a nice vignette. Developmental dysplasia of the hip, newborn, clunky hips, harness so that the acetabulum grows right. Legg-Calvé-Perthes disease, idiopathic avascular necrosis, an insidious onset antelogic gait, inability to bear weight. X-ray shows deformed femoral head. Get the weight off the femoral head, it will grow back normal. SCFE, growth spurt, obese, acute, unable to bear weight. Frog leg X-rays, pin. Septic arthritis is septic arthritis just like anywhere else. Get an arthrocentesis, antibiotic, drainage. Transient tenosynovitis, after viral illness, painful joints, wait for it to resolve. I'm going to go into now idiopathic scoliosis. And it's idiopathic because it's not caused by something else. And when someone says scoliosis, they mean this. Because it's idiopathic, it means also that the bones of the vertebra, ribs, etc., the bones are normal. Yet even though they are normal, there's a defect of the lateral curvature of the spine. There may also be lordosis or kyphosis, but scoliosis is a lateral curvature deformity. This happens in girls way more than boys, 7-to-1 ratio, and it is evaluated for during adolescence. And there are 3 severities, mild, moderate, and severe. Mild disease is asymptomatic. It's found on screening and on X-ray. Doesn't cause any problems. No cosmetic defect. Severe disease may impair respiratory function. In between is moderate, which is mostly a cosmetic deformity. And saying it like that, though that's the way it's written out, implies that this is just something that she prefers to look different, right? Significant curvature defects have a major impact on quality of life, not just how she looks. And based on the Cobb angle, mild, moderate, severe can be classified by the degree. I do 25 and 50. Less than 25 is mild, equal to more is 50 is severe, and in between is moderate, but obviously it's a spectrum. The diagnosis is made on a screening exam called the Adams test. The Adams test is the bend forward test. You have the child feet together, standing up, looking for asymmetry, mainly in the iliac crests and other landmarks of the pelvis. Then have the child bend over at the waist, arms dangling. What you're looking for is an asymmetry in the height of the scapula. If there is asymmetry, that means there is a curvature that needs to be codified and diagnosed by X-ray. And this is where you're going to get the Cobb angle. Do not learn how to calculate one, but that is what you're going to do on X-ray, as it determines the severity. The treatment comes down to severity as well. Mild may need nothing. Moderate, usually not correction, but a prevention of worsening of the angle. That can be done with bracing. Bracing is under the arm, essentially full torso bracing, which is super awkward and uncomfortable. And for an adolescent girl, may not have such great compliance with this. But if the disease is to be corrected and it's not severe, so it doesn't need surgery, bracing is the way to go. If severe, bracing is not enough. That requires surgery and correction of the curvature and stabilization of the bones using rods. Idiopathic scoliosis, girls, curve to the left or the right, Adams test, X-ray, bracing or rods. And this next one is essentially always on every exam that it can be. It goes by the name Osgood-Schlatters disease, an eponym that's very unhelpful. I think that it shows up so often because it is a great way to evaluate the knowledge and mastery over how bones grow. So let's start there, because this diagnosis is actually benign, takes care of itself. Essentially, you don't have to do anything for it, but it always shows up on licensing exams. We're talking about the tibia, and this is going to be gestural. I'm not trying to draw anatomy. We know that long bones have a cartilaginous growth plate called the physis. A secondary ossification center of the tibia on top of the physis is called the epiphysis. And on the other side of that physis is the metaphysis and diaphysis. And the meta and the di don't really matter for this discussion. The proximal tibia has another secondary ossification center. And it has a connection to the proximal tibia. This is the tibial tubercle, and its physis called the apophysis, the apophysis. The physis, separating the epiphysis from the metaphysis, fuses usually between 11 and 14. but the apophysis of the tibial tubercle doesn't fuse until around 18. Now, the exact ages don't matter. The fact that it's much later than the physis of the proximal tibial does. The tibial tubercle is the insertion point for some tendons of the quadriceps muscles. Osgood-Schlatters disease is actually named tibial tuberosity apophysis-itis. Apophysitis. Inflammation of the apophysis of the tibial tubercle. As long bones grow along, muscles need to stretch because they're already connected. As they do, they pull, creating tension on the tibial tubercle. The unfused cartilage is stressed by that pulling. And when a child does exercise or sports that involves the quadriceps, they put more tension on it. More tension, more inflammation, more pain. No avulsion, that would be a fracture, that would require intervention. This is just, this thing doesn't like being tugged on, and when tugged on a lot, it gets a little inflamed, and with a little inflammation comes a little bit of pain. And after the apophysis fuses, around 18, this is a non-issue. Only when this growth plate is still active can this be a problem. So, tibial tuberosity apophysis-itis is an overuse injury. Caused because the quadriceps insert onto a thing the tibial tubercle with its own unfused and still active physis, the apophysis, apophysis. The patient's going to be an adolescent athlete. And the exercise that uses the quadriceps muscles, runners, jumping, and doing a bunch of squats, is going to provoke pain. A palpable nodule, and where? At the tibial tuberosity, where the insertion point is. And it's worse after activity. It's not just like angina, activity hurts, stop, the pain goes away. It's the longer they rest for, the longer they don't do the activity, the better they get. And that's because it's not just use, it's inflammation. The diagnosis is clinical. No testing is needed. And the treatment comes down to what does the kid want to do? If the objective is to reduce pain, they have to stop all activity, let the inflammation cool off, then re-escalate slowly. If they do that, this is like weeks to months of doing no activity and then slowly re-escalating. If they do that, the pain's going to go away. If they don't, the pain's going to come back. But some kids want to play sports more than they care about the pain. This is not going to be a long-term problem that will go away. There might be a palpable nodule, but if they value playing sports over the absence of pain on their shin, they can be allowed to continue activity and just work through it. So, not a dangerous diagnosis, but one that's always tested. And I think it's because of this physis business. Back half of this lesson is going to be about bone tumors. And there are benign tumors and there are malignant tumors. They occur in long bones. Not surprising, because long bones grow long. In order to grow an organ, cells have to proliferate. Proliferation affords opportunity for mutations. The longer the long bone, the more proliferations there were. Thus, the longest long bones, femur, tibia, are the most common sites of these things. And because males tend to get taller than females, and to be taller, you have to have longer long bones. That's what makes people tall. These conditions occur in males more often than females. And so, the long bones of males, and they'll say range of 10 to 20, but I'm just going to say about 15, because all of them are going to have this demographic. And I'm going to first tell you the story that you need to hear for licensure. Then I will reveal the truth. Because the longest long bones are the femur and the tibia, I'm going to use the knee for our advanced organizer. This represents the diaphysis, cortex. There are benign growths in the diaphysis that induce a sclerosis, thickening of cortex. And there are malignant diaphysis tumors that are going to induce a progressive onion skinning as the cortex is repeatedly laid down as the tumor grows. So you get an onion skin appearance. There's going to be a malignant metaphysis tumor, which is going to demonstrate a sunburst pattern. This usually occurs near to the epiphyseal plate. And there's going to be a metaphysis benign growth, which will be confluent with cortex and medulla and be capped by cartilage. And then there will be a benign tumor of the epiphysis. And there is no malignant epiphysis tumor. The malignant tumors are the most important, so I'm going to start with those. The one that occurs in the medulla of the diaphysis is Ewing's sarcoma, and I think that this eponym should stick. It is a sarcoma, soft tissue tumor, that is caused by a translocation chromosome 11 to 22. Coincidentally and unrelated to this tumor, Patrick Ewing was a basketball player whose jersey number was 33. 11 plus 22 is 33. 1, 2, 3. Useful for remembering Ewing sarcoma translocation event. It is the bone tumor that will appear in the diaphysis, originating from the medulla, and it is a neuroendocrine tumor. The demographic: white males, about 15 years old. They're going to present with bone pain, fever, and cytopenias. The diagnosis will be made first by an X-ray, and this progressive layering of periosteum will give the appearance of onion skinning. An MRI will be obtained that will show that the tumor is of bone. A CT scan, bone window, can be used to show bone destruction, to look for metastases, but in terms of diagnosis, it is the MRI. A biopsy will show anaplastic cells that look like neuroendocrine tumor cells. The treatment is resection and usually chemo and radiation. Compare that to what's typically called osteosarcoma, better termed osteogenic sarcoma. It's a sarcoma. It is a sarcoma that makes osteoid. It's a malignancy. The cells that make osteoid are osteocytes and osteoblasts. This is a malignant tumor of osteoblasts. There are two ways of getting this. In primary disease, there's going to be a genetic syndrome. And the one I want you to associate with this is retinoblastoma. This is how kids get it. In secondary disease, it occurs secondary to something else. This is going to be Paget's disease of bone in the elderly. Osteoblasts proliferate uncontrolled in Paget's and convert into osteogenic sarcoma. In pediatrics, the kid is going to have retinoblastoma. They're going to have a tumor found at birth. And anticipating the need to evaluate for osteogenic sarcoma, there's going to be surveillance. Don't worry about what surveillance means. Just know that the oncologist already knows that there's a genetic syndrome and they're going to have to deal with this. But it still may present as a bone tumor, which causes bone pain, though this is usually not fever and cytopenias. The diagnosis is made with an X-ray, which will show a sunburst pattern and a Codman's triangle. An MRI will show that it is of bone. CT, bone window, looks for Mets. Ultimately, a biopsy will demonstrate cancerous osteoblasts, pleomorphic nuclei, elevated nuclear to cytoplasm ratio, etc. Stuff that says this is a dedifferentiating tumor, stem cells of which were derived from osteoblast progenitors. And these osteoblasts will be secreting osteoid. The treatment: resection, and no matter what the findings of staging is, prophylactic chemo because of micrometastases. Onion skinning, sunburst, Codman stuff, those are radiographic findings, bone cancer. Diaphysis, metaphysis, either one can be in either place. The point is, bone tumors present similarly and are managed similarly. X-ray, MRI, biopsy, resection, chemo. The chemo changes, I choose based on the cancer's oncotype. But this is what you should learn for licensure, that they are two distinct tumors. In addition, biopsy used to be en bloc resection, open surgery, remove good tissue with the tumor. It has been determined since then that that has a high morbidity. Sometimes even amputation was used both for treatment and diagnosis. Now, a core needle biopsy is used. A core needle was avoided because a core needle would seed the tract. The surgeon that does the biopsy should be the one doing the resection because surgical planning involves resection of the tumor and the tract. Ewing sarcoma, translocation 1122, osteogenic sarcoma, retinoblastoma. From there, it's X-ray, MRI, biopsy, resection, chemo. I've saved the lowest yield diagnoses on the list for the end. That is the benign bone tumors. The one in the diaphysis, the green one with the reactive sclerosis, is osteoid osteoma. This is a benign tumor. It's a tumor of osteoblasts. Osteoblasts become osteocytes, and they secrete osteoid, the matrix that could become ossified, but it won't. And so what happens is a soft tissue tumor develops within the medulla. Bone doesn't like having not bone and bone marrow near it. And whenever it finds something that's not bone or bone marrow, it reacts by becoming more like cortical bone. The sclerosis is reactive to the presence of the thing. This is going to present with pain. Usually that's worse at night and improved with NSAIDs. Males about 15. The thing is that this will go away on its own most of the time. The diagnosis is made with an X-ray. What you're looking for is central lucency. That's the tumor. And thickened cortex. Thickened relative to the rest of the diaphysis. You can use the CT bone window. The best test is an MRI. But usually you don't need to do anything because they're responsive to NSAIDs or aspirin and go away with time. Osteoid osteoma, we're getting pretty into the weeds here, but it still may come up, becomes osteoblastoma if osteoid osteoma fails to be treated, disappear over a couple of years, or if it's big, greater than or equal to 3 centimeters. The blue thing near the epiphyseal plate, but still in the metaphysis, is an osteochondroma. It is normal, but an aberrant tract. That is, it is derived from a normal growth plate. It just went off to the side. And it thinks it's the knee, so it's capped with cartilage. Because it's mostly normal bone, confluent medulla and cortex, bones that are normal bone don't hurt. It's usually asymptomatic. There may be a bump, but it's usually found on X-ray for something else. The diagnosis, X-ray. Treatment, only based on symptoms. On a licensing exam, though, if you obviously diagnose osteochondroma and there's stuff in there about cancer, it is possible, as part of a hereditary syndrome, that hereditary syndrome causes the cartilage to go malignant. That is an osteochondrosarcoma. That requires resection, and only if the vignette gives you a history of genetic or familial issues. And the worst offender of them all, the one of the epiphysis, the osteoclastoma. typically called a giant cell tumor. It's called a giant cell tumor because, like macrophages, osteoclasts are fused cells. The stem cell is induced to proliferate and fuse to become an inactive, multinucleated osteoclast. When activated on bone to clear bone, the osteoclast gets its ruffles and remains a multinucleated osteoclast. When overstimulated, more proliferation, more activation, and more fusion happens. So in an osteoclastoma, you're going to see a really, really big, really, really multinucleated cell on biopsy. Giant cell tumor. It's an osteoclastoma. Excess osteoclasts, clasts clear bone. It's benign. It's of osteoclasts. It's caused by increased expression of rank ligand. Rank ligand activates rank, which is responsible for proliferation and activation, causing overproliferation where these things are, and increased bone resorption. Why it's the worst offender? Because it's often tested against the others, but the incidence is highest in ages 20 to 40 years old. It will present with pain, pathologic fracture, or limited range of motion. Diagnosis, like most bone stuff, is an X-ray. It shows soap bubbles. That's why I drew the circles there. Multiple foci of bone clearing leading to a radiotranslucency. A biopsy, if done, but doesn't need to be done, would show the multinucleated giant cells. And even though they are benign, they are destructive, so resection. What I want you to get out of this is bone cancers present the same way. They have a different pathogenesis, and they're treated differently, but the diagnosis is, if bone pain, X-ray, MRI, biopsy, resection. For the benign conditions, recognize the radiographic appearance, the location, and the what do I need to know about this for the test. Osteoid osteoma should get better on its own with NSAIDs, cortical thickening with central translucency. NSAIDs in time, surgery if big or fails. For osteochondroma, if it's by itself, it's normal, bone in the wrong place, don't do anything about it unless it's symptomatic. If you catch wind of genetic syndromes, get it out because it will convert to osteochondrosarcoma. Osteoclastoma has nothing to do with being in a pediatrics lesson, but if you see it, it's caused by rank ligand. You do need to resect it because it'll only get bigger, worse, and cause pathologic fractures. And that is orthopedic pediatrics.